Okay, so we're diving deep today into some pretty fascinating research that's coming straight out of Japan.
Hmm.
You sent us this study, and it's all about getting better at predicting these BRCA1 and BRCA2 gene mutations, but specifically in Japanese women who've been diagnosed with breast cancer.
Yeah, that's right. And for anyone listening who maybe it needs a little refresher, those BRCA genes are really important because they're closely tied to this thing called hereditary breast and ovarian cancer syndrome. We call it HBOC for short.
Right, HBOC?
Exactly. And so if those genes have, changes, we call those pathogenic variants, mutations, it really increases a woman's risk of developing those cancers.
Yeah.
And so being able to spot those mutations early on is really critical, for managing those risks and for thinking about preventative measures.
Absolutely, and I think one of the things that makes this study that you sent over so interesting is it's the first prediction model that has been developed just for Japanese patients, right?
Exactly, yeah.
It's using all this info from the Japanese Organization of Hereditary Breast and Ovarian Cancer.
Oh.
So JOHBOC.
Yep.
JOHBOC.
We like our acronyms, right? And,
Uh-huh.
the thing is, most of the tools we have now to predict these mutations were actually developed using data from European populations.
Mm-hmm.
So this could be a game changer in terms of accuracy.
Absolutely, and that's exactly why this is such a perfect topic for a deep dive.
Yeah.
I mean, we really want to get to the bottom of what this research found.
Yeah.
What are those factors that are so important in predicting these mutations in Japanese women? And really, why does this research matter so much?
Okay, so let's really break this down and start with some background on HBOC and these BRCA genes.
Sure. So HBOC syndrome is basically caused by those pathogenic variants. We talked about those mutations
Right.
in the BRCA1 and BRCA2 genes. And normally these genes have a super important job.
Okay.
They're like the repair crew for damaged DNA.
Mm-hmm.
They help to regulate how cells grow, and they even work to stop tumors from forming. But when they're not working the way they should because of a mutation, that's when the risk of certain cancers really starts to climb. And when you say climb, I mean, we're talking a significant increase in risk here, right?
Oh, yeah, absolutely. I mean, the study points out that if you look at women with a BRCA1 mutation, their lifetime risk of developing breast cancer by the time they reach 70,
Okay.
it's estimated to be around 57%.
Wow.
And for those with the BRCA2 mutation, it's about 49%.
Still really high.
Right. And it's not just the initial risk of getting cancer either. The risk of developing a second breast cancer, that also goes up significantly.
Okay.
So for women who already have a history of breast cancer because of HBOC, the chance of developing another breast cancer in the other breast within 20 years,
Okay.
it's actually 40% for BRCA1 carriers and 26% for BRCA2 carriers.
Wow, those numbers are significant.
Yeah.
I mean, it really highlights why it is so important to identify these mutations so we can catch them early.
For sure.
Now, I know that insurance coverage for BRCA testing has gotten a lot better in Japan in recent years.
It has.
Have you seen that kind of changing the landscape at all?
Oh, absolutely. It's been a huge shift.
Yeah.
I mean, back in 2018, that's when they first expanded the insurance coverage in Japan. And it initially started with covering those tests that help doctors figure out which breast cancer patients with recurrent disease might benefit from something called PRP inhibitors.
Okay.
And these are drugs that work really well in BRCA mutation carriers.
Gotcha.
Then in 2020, they made it even better. They expanded the coverage even more to include the diagnosis of HBOC itself.
Okay.
And also preventative measures like mastectomies or oophorectomies.
Yeah.
So now that more people have access to testing, it's really raised awareness and more folks are seeking it out.
And it seems like the results from the Olympia trial have played a role in this too, haven't they?
Oh, for sure. The Olympia trial was a big deal because it showed that these PRP inhibitors,
Right.
if they're given after the initial cancer treatment, so as what we call adjuvant therapy,
Uh-huh.
they could really benefit HBOC patients with BRCA mutations.
Okay.
But they had to meet specific criteria, of course. And so based on those findings, the Japanese Breast Cancer Society, they updated their guidelines in 2022.
Okay.
And now they recommend PRP inhibitors as an option in these cases.
Interesting.
Yeah. So this just further emphasizes how important BRCA testing is,
Yeah.
not just for surgical decisions and managing that future cancer risk,
Mm-hmm.
but also for planning that next important treatment step after surgery.
Okay, so with this growing need for BRCA testing, I'm curious to know, what were the criteria being used in Japan to even decide who should get tested before this new model came out?
Well, they've mainly been relying on these international guidelines.
Okay.
And the NCCN guidelines, those are from the National Comprehensive Cancer Network. Those are a big one.
Okay.
And they basically have this list of features, clinical and pathological features that might suggest that someone has a higher chance of having one of these BRCA mutations. So if a patient meets one or more of these criteria, like say they have a really strong family history of breast or ovarian cancer, or they were diagnosed with breast cancer at a young age, then they would typically recommend genetic testing.
Makes sense. But this new study is saying that maybe just relying on these international guidelines isn't the best approach, specifically for Japanese women.
That's what they're suggesting. Yeah. They're saying, look, it's totally possible that some Japanese people who actually have HBOC might not meet those criteria from those international guidelines, and they could be missed. Clinicians in Japan have been seeing this.
Really?
Where someone might only have one of those criteria on the list, but they end up having a BRCA mutation.
Oh, wow.
While other people who meet a bunch of the criteria don't have the mutation.
Interesting. So that's where having these specific prediction tools becomes even more valuable.
Exactly. It helps to fine-tune those decisions.
And there are already some prediction models out there, right?
Oh, yeah, there are a bunch.
I know the study mentioned a few.
Yeah, you've got BRCA, the Tyrer-Cuzick risk assessment tool, Boadicea.
Right.
And even some that are specifically for certain ethnicities, like Coechial, that one's for Koreans, and Arika, which is designed for Asians. And all of these tools are used in genetic counseling to help people and their doctors figure out if genetic testing is a good idea.
So they're using them in Japan too, then?
Oh, yeah. They're definitely used there as well.
Okay, but as we were talking about before, the populations that these models were developed for could be pretty different from each other.
Exactly. And that's a major limitation, because those different ethnic backgrounds and the specific populations that they use to create these models, they're not always a good representation of what we see in the Japanese population. And that's why we're seeing this growing need for risk models that are made for specific ethnic groups.
Makes sense.
Because think about it, if you have a model that was built using mostly data from Europeans, it might not be accurate at predicting the risk in Asian populations.
Yeah.
And in fact, some studies have even suggested that BRCA Pro, which is one of the most widely used models, it might actually underestimate the number of BRCA mutation carriers among Asians.
Oh, wow. So that's a problem. Okay, well, this brings us back to this Japanese study and what they were trying to do.
Yeah, this is where it all comes together. The whole point of this research was to address that gap. They wanted to pinpoint those clinical and pathological factors that are specifically linked to HBOC in Japanese patients.
Okay.
And then use that information to create a brand new prediction model that's custom made for that population.
And they were using the data from the JOHBOC registry for this, right?
Exactly. They used that really valuable resource.
Cool. So the hope is that this Japan-specific model will be way better at identifying those Japanese breast cancer patients who should be getting the BRCA testing.
That's the idea, yeah.
And it could even help to paint a clearer picture of how HBOC looks genetically within Japan.
Exactly.
That's so interesting. Okay, so let's dig into this study itself.
Okay.
Can you tell us about the data they used and how they actually went about doing this research?
Sure. So the researchers went back and looked at data that had been collected by JOHBOC from 62 different medical centers all across Japan.
Wow, that's a lot.
It is, and it spans a long period, too, from 1996 to 2019.
Wow.
So it's a pretty extensive data set, and JOHBOC is really important in Japan.
Yeah.
They're all about tracking HBOC cases, conducting research, and educating healthcare providers so that we can manage HBOC better.
It sounds like they're doing really important work.
They really are.
So how many patients were included in this analysis?
They included a total of 72 Japanese women.
Wow.
Who had been diagnosed with breast cancer and had undergone that BRCA12 genetic testing.
Okay.
And they were tested because there was some suspicion of HBOC.
Okay.
So that's a really good number of individuals to be working with.
Sure.
It gives you a lot of power to draw some solid conclusions.
Okay, so who did the actual genetic testing in these cases?
So the vast majority of it, about 75%, was done by a company called Falco Biosystems.
Okay.
And another 15% was done by Myriad Genetic Laboratories. And then the remaining 10% was done by a mix of other research institutions, some in Japan, some international.
Gotcha.
But importantly, they said that the way they interpreted the genetic changes that they found,
okay,
that was all based on the standards set by Myriad Genetic Laboratories.
Okay. Makes sense. So how did they go about building their prediction models and then testing them out to see if they actually worked?
Well, they used a pretty common statistical approach called the holdout method.
Okay.
It's kind of like this. Imagine you have your entire group of patients and you randomly divide them into two smaller groups.
Right.
So one group, which in this case was 70% of the data,
Okay.
that's 2,150 patients. That's called the development group.
Gotcha.
And this is the group that they used to build their prediction models.
Okay.
To see which factors were most strongly related to having that BRCA mutation.
Uh-huh.
Now, the other group, that's the remaining 30%.
Okay.
So 922 patients, that's called the validation group.
Gotcha.
And they keep that group separate. They only use it at the very end to test how well the models that they built on the first group actually work on new data that the models haven't seen before.
Oh, that's smart.
Yeah, it's a really good way to make sure that the model isn't just overfitting to the data that it was trained on, you know?
Right.
It helps to ensure that it can actually be accurate in real-world scenarios.
Yeah, like it can actually be used in a clinical setting.
Exactly.
That makes a lot of sense. So what statistical methods did they actually use to figure out which factors were the most important ones?
Well, first, within that development group,
Yeah.
they use something called logistic univariate analysis.
Okay.
And this is basically looking at each factor on its own,
Okay.
like age at diagnosis or tumor grade,
Mm-hmm.
and seeing if it has a link to whether or not someone has a BRCA mutation,
Gotcha.
and if there was any missing information for a particular factor. They just did the analysis on the cases where they had that information.
Okay.
Then from those factors that showed a significant link,
Mm.
in that first analysis, they picked the ones that would be useful clinically
Right.
and included those in a more complex analysis called logistic regression multivariate analysis.
Okay.
And this allows them to look at multiple factors together at the same time
Okay.
and see which ones are independently associated with those BRCA mutations.
So they're not just looking at each thing on its own. They're looking at how they all work together.
Exactly. It's like figuring out which ingredients in a recipe really make a difference.
I like that analogy.
Yeah, it's a good way to think about it. And it's worth noting that they actually decided to leave out the Chi-67 index,
Okay.
which measures how quickly cancer cells are dividing,
Mm-hmm.
because they were missing that information for quite a few patients.
Okay. So they wanted to make sure they were using data that was complete.
Exactly. They wanted to be thorough. And they had this step-by-step way of selecting which factors to include in the analysis.
Okay.
And in the end, they built 3 separate prediction models.
Yeah.
One for any BRCA1 or BRCA2 mutation, one specifically for BRCA1 mutations,
Okay.
and one just for BRCA2 mutations.
Gotcha. So they were looking at it from all those different angles.
Exactly. And then they tested those models on that separate validation group
Okay.
by looking at these things called ROC curves and
Yep.
calculating the area under the curve, or AUC.
Right. AUC, we see that a lot in research.
Yeah, it's basically a way to measure how good the model is at telling the difference between people who have the mutation and those who don't.
Okay. That makes sense. So let's get to the good stuff, the results.
Yes, let's do it.
What did they find when they looked at predicting BRCA12 mutations, just in general? What were some of the key red flags, so to speak?
Okay, so when they looked at the entire group, those 3072 women, they found that 18.4%, or 566 of them, had a pathogenic variant in either BRCA1 or BRCA2.
Okay.
So when they did that more complex analysis in the development group to predict just any BRCA12 mutation,
Mm-hmm.
they found a few really important factors. One was having a tumor with a nuclear grade of 2 or 3. And nuclear grade is basically how abnormal those cancer cells look under a microscope.
Okay.
And higher grades usually mean the cancer is more aggressive.
Gotcha.
They also found that having triple negative breast cancer,
Right.
or TNBC, that was a significant predictor.
Okay.
And TNBC is a type of breast cancer that doesn't have certain receptors.
Okay.
And then on top of that, a history of ovarian cancer, or even a family history of ovarian cancer, that increased the likelihood of having a BRCA12 mutation.
Okay.
Younger age at diagnosis.
Right.
Having more relatives with breast cancer, and
Right.
having a younger age of the youngest relative who was diagnosed with breast cancer.
Okay.
All of those were significantly linked to BRCA12 mutations as well.
So it sounds like there are a lot of factors that can point to a higher risk.
There are a lot of pieces to the puzzle.
Yeah, so how well did their prediction model for BRCA12 do in that validation group?
Well, in the development group where they built the model, it had an AUC of 0.804. And then when they tested it out on that separate validation group, the AUC was 0.777.
Okay.
And generally speaking, an AUC that's above zero point 0.7, that's considered pretty decent.
Mm-hmm.
And above zero point 0.8 is even better.
Yeah.
So these are really promising results. It suggests the model is doing a good job of telling the difference between who has a BRCA12 mutation and who doesn't.
That's great to hear. And what about when they zeroed in specifically on BRCA1 mutations? Did they see the same important factors, or were there any differences there?
There were some similarities, but there were also some interesting differences.
Okay, I like differences.
Yeah. So they found that 9.9% of the total group, that's 303 women, had a BRCA1 mutation.
Okay.
And when they specifically looked at the factors linked to BRCA1 mutations, a lot of the same things popped up. Nuclear grade 2 or 3, TNBC, family history of ovarian cancer, younger age at diagnosis, which makes sense given what we found for BRCA12 overall.
Right.
But they also found that having more lymph nodes with metastasis, that means the cancer had spread to more lymph nodes, and a younger age of the youngest relative with breast cancer, those were significant predictors, specifically for BRCA1.
Interesting. So it sounds like those are some specific things to look out for with BRCA1.
Exactly.
Okay, so how did that BRCA1 prediction model perform on its own? Was it better than the combined model?
It actually did even better.
Really?
Yeah, it achieved a really high AUC of 0.879 in the development group.
Wow.
And an even higher AUC of 0.898 in the validation group.
That's impressive. So that means it's really good at picking out those individuals who are likely to have that BRCA1 mutation.
Yeah, it's really good at its job.
That's awesome.
Yeah.
I know the study mentioned the connection between BRCA1 and more aggressive tumor features. Can you explain that a little bit more?
Sure. So breast cancers that are linked to BRCA1 mutations, they often have more aggressive characteristics, like being triple negative, which means they don't express the estrogen receptor, the progesterone receptor, or the HER2 protein, and having a higher nuclear grade, which, remember, means that the cancer cells look more abnormal and they tend to grow faster.
Yeah.
So this connection between BRCA1 and these aggressive features, it helps us to understand better how BRCA1 mutations actually show up in breast cancer.
Okay, so it's giving us more insight into what's actually happening at the cellular level.
Exactly.
That's fascinating.
Okay.
So let's switch gears a little bit. What about the findings for BRCA2 mutations specifically?
All right, so for BRCA2, they found that 8.4% of the whole group, so 257 women, had a BRCA2 mutation. And the interesting thing here is that the factors that were associated with BRCA2 mutations were kind of the opposite of what they found for BRCA1.
Oh, really? Okay.
Yeah. So the absence of TNBC was actually linked to a higher chance of having a BRCA2 mutation.
Wow, that's the complete opposite.
It is completely flipped.
All right.
Younger age at diagnosis, having more relatives with breast cancer, and a younger age of the youngest relative with breast cancer, those were still important for BRCA2. But that TNBC finding that was really striking.
So how did the prediction model for BRCA2 do?
Well, it didn't perform as well as the BRCA1 model.
Okay.
It had an AUC of 0.669 in the development group and 0.647 in the validation group.
Okay.
So those numbers still suggest that the model has some predictive ability.
Right.
But the researchers think the lower performance might be because of a couple things.
Oh.
First off, there were just fewer BRCA2 positive cases in the study compared to BRCA1.
Okay.
And that can make it harder to build a really strong model.
Makes sense.
And second, they think that BRCA2 mutations might not have as many clear-cut clinical features compared to BRCA1, which makes them trickier to predict just based on those factors.
So it's almost like BRCA2 is a little bit more subtle in how it presents.
In a way, yeah, it's not quite as straightforward.
Okay. I'm still really hung up on that whole TNBC thing. It's so interesting that it has opposite associations with BRCA1 and BRCA2. What does that tell us about these two genes?
It's a big clue, you know. The fact that TNBC was more common in BRCA1-related cancers, but less common in BRCA2-related cancers, it really tells us that even though both of these genes are involved in HBOC, they can act really differently when it comes to how their mutations show up in breast cancer.
So they're not exactly interchangeable, even though they both play a role in HBOC.
Exactly. They're both important players.
Right.
But they have different roles.
Okay. That's a good way to put it. And were there any factors that consistently showed up as being important across all three of the models? The BRCA12, the BRCA1, and the BRCA2?
Yeah, there were a couple of really consistent ones. Younger age at diagnosis. And a younger age of relatives diagnosed with breast cancer.
Okay.
Those were significant in all three models.
So those are really the big ones to watch out for.
Yeah, those are definitely red flags.
And this makes sense, right? Because we've always known that there's a link between early onset breast cancer and a higher chance of having those HBOC-related mutations.
Exactly. It all ties together.
So let's bring this all home. Why is developing this Japan-specific model such a big deal for people in Japan?
Well, it all comes down to identifying those individuals who should really be considered for testing.
Okay.
By using a model that's made for their specific population,
Right.
we have a better chance of catching those who might be missed by those more general international criteria.
And as we talked about before, those guidelines might not be the best fit for everyone in Japan.
Exactly. One size doesn't fit all when it comes to genetics.
And what kind of benefits do you see coming from this better identification for individuals and even for the healthcare system in general?
Well, for individuals, it could be huge.
Yeah.
Better risk assessment means that we can be more precise about figuring out someone's chances of having a BRCA mutation.
Mm-hmm.
And that leads to more targeted screening. So maybe they start mammograms earlier or get them more often.
Right.
And it can also help to guide those big decisions about preventative measures, like prophylactic surgeries to lower the risk of breast and ovarian cancer in people who are at high risk.
Yeah, that's a big one.
It is. And then looking at the bigger picture, it could make healthcare systems more efficient because you're directing resources towards the people who truly need them.
Right.
And you can potentially avoid unnecessary testing in people who are at lower risk.
And that could save money, too.
It could. And then there's the whole issue of PRP inhibitors.
Right.
Remember, those are becoming increasingly popular as a post-surgery treatment option for breast cancer.
Right.
Especially for those with BRCA mutations.
Yeah.
So this model could be really helpful for identifying patients who would be good candidates for that therapy based on what we learned from the Olympia trial.
That makes a lot of sense.
Yeah.
So it sounds like this model could have a ripple effect in a lot of different areas.
It really could. It's pretty exciting.
It is, of course, no research is perfect. So what were some of the limitations that the study authors pointed out?
Well, one thing they mentioned is that their model mainly uses information that's gathered after surgery.
Okay.
But in reality, genetic testing often happens before surgery to help plan things out.
Right.
So developing models that can use information that's available before surgery would be really valuable.
That makes sense. So it's more applicable to real-world scenarios.
Exactly. And they also had to leave out some information that could have been helpful.
Well, really?
Yeah, things like that Chi-67 index.
Right, the cell growth measure.
Right, because they didn't have that data for everyone in the registry.
Okay, so it sounds like data completeness is a challenge.
It can be, and they also recognize that future models should try to incorporate clinical factors that are more consistently available.
Yeah.
Another limitation, we touched on this before, was that they had fewer BRCA2 cases than BRCA1 cases,
Right.
which could have affected the accuracy of their BRCA2 model.
Oh, okay.
They also pointed out that their study group was recruited before BRCA testing was widely covered by insurance. So their group might have included more people who were already thought to have a high chance of having HBOC.
Right, because they were more likely to be getting tested in the first place.
Exactly. And lastly, they tested their model by splitting their group of Japanese patients into two.
Right.
Which gives us a good starting point.
Mm-hmm.
But they emphasize that it's really important to test it out on a completely independent group of Japanese patients.
To really make sure that it's accurate.
Yeah, to get a more solid assessment of how well it performs.
That makes a lot of sense.
Mm-hmm.
Okay, so as we wrap up this deep dive, what's the big takeaway here? What do you want our listeners to remember?
I think the main message is that this study was successful in developing that first prediction model just for Japanese women with breast cancer to figure out their risk of having those BRCA mutations. And the results are looking especially good for predicting BRCA1 mutations.
That's great.
It is. And it has the potential to really change the game for how we assess breast cancer risk in Japan.
Yeah, and what does all of this mean for our listeners in Japan and for anyone else who's interested in this topic?
Well, it means that there's a new tool out there that can help to identify individuals who might be at higher risk, and that can lead to more personalized decisions about genetic testing and ultimately better prevention and treatment strategies.
That's a huge step forward in personalized medicine.
It is.
It makes you think, this model is designed for the Japanese population.
Mm-hmm.
So what other genetic predispositions for all sorts of health conditions around the world could benefit from this kind of research that takes a person's ethnicity into account?
That's a great question.
It's exciting to think about all the possibilities for tailoring our medical approaches to different populations.
It is.
Thanks for taking this deep dive with us.
It's my pleasure.
This was really interesting.
That is fun.
Always love chatting with you.
Likewise.
All right, everyone. Thanks for listening. We'll catch you next time.
See you later.